right, good evening, everyone. I think what was missed out is that the work that we do is actually with FHI 360 Kenya, and I can describe a little bit of how we work with these populations at home. So FHI 360 is working with MSM, sex workers, both male and female, and transgender populations globally through two projects. One is Linkages, which is in, I think, over 30 countries, many of them in sub-Saharan Africa, and EPIC, which is still working with the same population, but also now with other groups that may be at risk of HIV other than key populations. For example, the partners and clients of sex workers and MSM, for example. So this work that we've been doing in Kenya, we've been there since 2016, and we are continuing to date. It's, I think, the largest key population program so far. We have, as of end of the last financial year, we had about more than 50,000 female sex workers in the program, and more than 12,000 MSM spread out over 16 counties, very diverse. Most are situated around urban areas, but we also have some of the counties being more rural. Our package of service includes two components. So the essential services that we provide to the populations, and then desirable, where if the opportunity arises, we do, but if it is not able to, then we consider it something that we are not able to do. So for the essential services, we have HIV testing, which could be testing by us directly or through referral to other facilities, provision of condoms and lubricants, addressing gender-based violence, either directly or through referral, working with peer educators to provide certain services like health education, provision of PrEP, provision of post-exposure prophylaxis as well, and we also had family planning or contraceptive provision, education and provision. So in the beginning, the program was very much prevention, and it has evolved with time based on the needs of the community that we serve. In Kenya specifically, we are working with female sex workers, male sex workers, and MSM. We were not working with transgender populations because until very recently, transgender populations were not recognized as a key population in Kenya. Thankfully, that has changed, and the guidelines are now being made. So when we were doing these services, the desirable components are things like HIV prevention, HIV treatment services, because those were not available everywhere in the places that we worked with. And of course, everything else that goes along with that, the psychosocial counseling and so on. One of the key things that we were supposed to do is identify those who are positive and link them to services, as well as keep the ones who are negative through different mechanisms as per the program. But with time, things keep evolving. So one of the key things that we were providing as part of the essential service that I forgot to mention is STI screening. In the beginning, it was actually not essential because STI drugs are not available everywhere, so we used to screen and refer. And there was a lot of pushback from the community. Why should you screen me and then send me somewhere else? So we lobbied with our donor, and we managed to get STI drugs to the facilities. And we saw quite a lot of people being attracted to the facilities that we were working with because of that. One of the other things that we noticed is there was a lot of challenge when it comes to stigma and discrimination. And because these populations that we work in Kenya are criminalized, like many of the countries in sub-Saharan Africa, the activity is criminalized, particularly if you're a former British colony. They don't criminalize the person, but they criminalize the activity, which is quite interesting. So it's bad to live on the proceeds of sex work, but the sex work itself is not condemned per se, or sodomy, but not necessarily homosexuality is criminalized. So it's interesting in that that also creates a bit of a problem when we are thinking about access to services. And as Dr. Etienne has mentioned, even within the healthcare workers, the areas that we work with public health facilities, some people have never really seen a key population member. So when you have someone coming in for, say, an STI, maybe they have anal warts or another STI, you find the service provider, first of all, calling their friends to come and see And then now, they discuss, so come and see this case. So it's not even come and see this person, it's come and see this case. So of course that means people will not come. Or they start praying for them, young woman, why are you a sex worker? It's bad, and so on and so forth. And since many of these sex workers are young, first of all, they get double stigma. So you are young, where are you? What do you want to access? Why are you having an STI? You're having sex. Then you're a sex worker, so that's an additional stigma. And woe unto you if you're HIV positive. That's a third level of stigma. So those have become barriers that we need to address in our program, and we are doing so through several ways. So the model of implementation of our particular program is three-pronged. So we have safe spaces or drop-in centers, which are centers where these key population members can meet, rest, relax, and at the same time get biomedical interventions. We work with public health facilities. We work with the sex workers and the MSM to identify facilities that they think they can access or they think are good for them, and we work with them to sensitize particular health workers in those facilities on how to provide stigma and discrimination-free services. And then the last model is outreach model, where we do outreaches to the hotspots. So these are the bars, the clubs, and so on. One of the key things we realized is that sex workers, yes, you'll find them in the bars and the clubs, but the MSM don't necessarily hang out somewhere in bars and clubs. There's quite a number who we have to think about reaching online. And a current study by the NASCOP, which is the National AIDS and STI Control Program, revealed that 25% of MSM are online. You won't find them hanging out in bars and clubs. So if you're thinking of an intervention in Kenya, reaching to MSM, you have to think about going online. And our program actually has a going online platform that we use to reach out to the digitally based MSM to try and link them to services in areas where they would wish to access these services. Currently, this is in Nairobi only. And we hope that that can be expanded. So those are a snapshot of the kind of work that we do.